Yes.
Okay. Okay. Hello, everyone. I'm Zui. I'm from radiology basic class in Vidic Hospital K2. Today, I have a presentation about image findings in brain development venous anomalies. I hope that we can share some kind of playlist knowledge during the long day of quarantine in COVID-19 pandemic. So let's jump in. Okay, the first one. In order to understand about DVA, we should talk about a little bit about introduction. Developmental venous anomalies, or DVAs, previously called the venous angiomas, are the most frequently encountered cerebrovascular malformation. Most likely, we consider the DVA as a malformation. However, nowadays, DVA is considered to be rather than an extreme developmental anatomical variation of major events than true malformation. Nowadays, they consider the DVA as an anatomical variation. In Vietnamese, we call it biến thể giải phẫu, more than a malformation, một loại dị dạng. So why? In order to understand the DVA, let's talk a little bit about the anatomic review. The veins of cerebral hemisphere can be divided into two systems. The first one is superficial system, and the second one is deep venous system. The superficial system like the cortical vein or the vein in superior sagittal sinus, which most likely drain the blood from the cortical gray matter and the subcortical white matter region in superficial region. The second system is deep venous system, deep territory, like the vein of Galen, like vein of Rosenthal, or internal cerebral vein, or thermostriate vein, which most likely drain the blood flow from the deep region of the brain, like the deep white matter or deep gray matter, into the deep venous system. That's the normal story, where the superficial territory drain into superficial vein system, deep venous territory drain into deep venous vein system. But what is DVA? DVA occurs when the deep venous territory drain into superficial venous system, and superficial venous territory drain into deep venous system. You can see here this is the deep venous system, the deep white matter, which cover into a point and drain into a collecting vein and come back to the superficial venous system. This is abnormal, and this kind of thing create the thing we call DVAs. The second story, when this is the superficial venous territory, which is drained into the deep venous system and come into a collecting vein. So two kind of this situation will become the DVA, what we're going to talk about today. Okay, about the etiologies. That's the mechanism. About the etiologies, the etiologies of DVA is not well understood, but we have some theory. The first one is that they think about the DVA. Maybe the DVA can be formed due to a venous after a venous thrombosis. But but as I said earlier, nowadays they consider the DVA as an anatomic variation. So the kind of thing, we just have abnormal in vascular structure. We have no neural tissue damage. So if we have a venous thrombosis, we should have a neural tissue damage. So it's not present in here. So that kind of theory is not really true. The second, they think about that maybe the DVA is a result of a cortical cell migration, but it's not true, because we still see the DVA in the central region, like in basal ganglia, or in region, or in brainstem. So it's not a true theory. And the most reliable theory, which is generally accepted, is the DVA is a result from an aplasia, hypoplasia, on early occlusion of normal development events, meaning that there's something wrong. For example, there's something wrong with the venous development in the deep region, for example. So the vein in superficial region running and collecting the blood flow in order to compensate the abnormal, the hypoplasia. So it's so I think about the DVI like a compensatory venous system developing for an anatomic adaptation more than a vascular malformation, as we earlier understand about that. About the radiographic characteristics on CT, DVIs are characterized by a cluster of venous radicals that converge into a collecting vein, resulting in a typical caput medusae appearance of the DVI. In addition, non-contrast CT may disclose the associated of hemorrhage, parenchymal calcifications, atrophy, or Y lesion in the drainage territory of the DVI. But most likely the caput medusa is the main character in here. Caput medusa or head of medusa. What is head of medusa? Head medusa is the name of the appearance reminiscent of Medusa, a monster of Greek mythology who got a beautiful face with a lot of snake on her head, which represent for all of her hair turned into snakes like that. And finally, that kind of monster was defeated by a hero in Greek ancient called Perseus. So they use the name. So you can see in here that kind of development of venous anomaly. It look like this is look like the head of the Medusa, and this kind of branches look like the hair of Medusa, right? So because of Medusa, on the SI, angiographically, normally DVI can be easily diagnosed on CTA or MRI. Normally, they do not require a modification like the SA. The SA is normally required in case of atypical hemorrhage. We're going to talk about that later in arterial DVI, for example. I'm going to talk about that in the next section of my presentation. On angiographically, the caput medusa appearance with a lot of collection of dilated medullary vein converge into a point and enlarges the transcortical or subependymal collector vein, a pathognomic scene. And you have to take in the back of your mind that this kind of appearance only be seen in the venous phase, of DVI, because we are talking about a case of venous abnormalities. So that kind of feature can help us to distinguish with the other kind of vascular malformation like AVM or AVF, because that kind of thing happens. The shunting between the arterial and the venous. So this kind of thing will have early venous draining, and it can be seen on arterial phase, but DVI can only be seen in the venous phase. Have to take it in the back of the mind, because we're going to talk about some kind of specific type of DVI in the next section. Okay, about supervision, let's go through a case. A 50 years old man who presented with small post-Rolandic hemorrhage in the brain, and on the CTA, on the DSA venous phase, you can see an appearance of caput medusa with a lot of radical converging vein come into a big collecting vein, and that kind of vein come into vein of Choler, and come into the superficial sagittal sinus, and here you can take back that we still some other venous drainage come into vein of Levy. 4 years later, this patient present with a symptom of lobar hemorrhage in the frontoparietal temporal and intraventricular hemorrhage. And on a DSA in venous phase, you can see the appearance, the disappear of the caput medusa image, but we still can see the image of the collecting vein, which is most likely appropriate with a case of venous thrombosis in DVI. Okay, normally, you know that normally DVI is considered as an anatomic variation. Normally they do not cause any kind of symptom like hemorrhage, like calcification. It's very rare. It has, but it's very rare. But DVI But in case of DVA, hemorrhagic DVA present with hemorrhage, most likely reason DVA come with cavernous malformation or CM. The coexistence of cavernous malformation and DVA occurs at a rate of 13 to 40%. Furthermore, the several studies have suggested that the cavernous malformations that are associated with DVA are more aggressive. There are a couple, but they should not come together, because when they come together, it is the case of aggressive. Why? Because the hemorrhagic incident in cavernous malformation that were associated with DVA may be higher than 2.6 and 3.1% per patient years that were reported for isolated cavernous malformation. So they should not come together, right? Okay, we have a case of repeated microhemorrhage around the DVA possibility. So how about the mechanism? How about the mechanism of DVA and CM? Why do they frequently come together? They have some theory, a theory that repeated of microhemorrhage around the DVA, possibly resulting from blood leaking through the walls of the venous radicals of the caput medusa, that are considered to reduce the cavernous malformation by activating the angiogenic growth factor, such as the vascular endothelial growth factor. So they think about that maybe due to the present of development of venous anomaly, the pressure in blood flow in here can be changed. The blood flow, the venous can be dilated, and the blood leak through the vascular wall. And when the venous leak through the vascular wall, it induces it activating the angiogenic growth factor, such as the vascular endothelial growth factor, and present some kind of abnormalities in the blood vessel, like cavernous malformation. They reported that the cavernous malformation associated with DVAs are always located in the territory of DVA, more precisely in the area subjected to hemodynamic change. In here, we have a case of on T2. You can see an appearance of a lot of popcorn appearance with or grape-like or blueberry or berry-like appearance with hemociliary ring surround, which is more likely represent for cavernous malformation. And on sagittal T1, you can see the appearance of caput medusa appearance beside the cavernous malformation, represent for a case of cavernous malformation and DVA. Okay, in a report about the development of venous anomaly, benign or not benign, which is published in 2016, they said that maybe the number about 30% between the cavernous malformation and DVA is not true. Maybe it's not true, because in the report of the cavernous malformation, initially diagnosed as just isolated of cavernous malformation were found to be associated with venous anomaly, either intraoperatively or by using the 7 Tesla MRI. So maybe we have a case of a couple between the DVA and cavernous malformation, but is not present in the MRI. We missed this due to some kind of limitation in our machine, or some kind of the other region. But it can be found in intraoperatively or using the 7 Tesla MRI. And the report suggested that the DVA is associated with cavernous malformation in the brain stem, and the spine may represent the dilated venous structure only related to cavernous malformation, and not the true DVA, as the lack of typical caput medusa appearance. Maybe it's still present, but it present in an atypical appearance. So the story about they just come together in 30% of cases, maybe not true. Okay, how about the DVA? We already know that the DVA is just an anatomic variation, so they just a kind of vascular abnormality only. They do not affect the surrounding brain parenchyma. But sometimes the parenchyma drained by DVA is generally considered. Sometimes it can be it can be happen. The parenchyma drained by DVA is generally considered to be normal, but in a report of Zuis that the brain abnormalities within the territory of DVA can have some kind of abnormalities like atrophy in 29.7%, like Y matter lesion in 28.3%, and dystrophic calcification in 9.6% of cases. And the chronic local venous congestion leads to the phenomenon. So see all kinds of phenomena due to the chronic local venous congestion. And you see here, you see a DVA on contrast T1, and on T2 you see some kind of hypersignal region due to the gliosis appearance. Okay, that's what all we have talked about the DVA, our story about the normal DVA, the common DVA or typical DVA. But what about the other specific type, spectral type DVA? We call the arterial line DVA. Arterial line DVA is DVA with early venous draining in arterial phase. That kind of abnormality that sound a little bit look like a little bit crazy, right? Because we are talking about a venous abnormalities. We are talking about a venous abnormality just only can be seen in the venous phase of DSA. But now we are talking about DVA on arterial phase. That kind of thing. And normally, you know that DVA normally do not cause the hemorrhage. DVA cause hemorrhage most likely related with the cavernous malformation. It's the primary case. In secondary case, after the DVA with cavernous malformation, hemorrhagic DVA unrelated to carcinoma can be arterial line DVAs. And that kind of situation occur when accompanied by a number of micro arterial venous communication, which represent with capillary blush appearance. Okay, in another research about the development of venous anomaly with arterial component, a rare cause of intracranial hemorrhage, they said that just it's an extremely rare type of DVA, which is only 53 cases of arterial line DVA had been reported, and amongst the 53 cases, at least 19 or 36% were associated with intracranial hemorrhage, and bleeding appears to occur more frequently in case of arterialized DVA than in the case of DVA without an arteriovenous shunt. Okay, in case of arterialized DVA, it can be subdivided into three types. The type 1 DVA with diffuse arteriovenous shunt, or with the appearance of capillary blush lines. Type 2 with DVA with micro arteriovenous shunt. In type 1, we just have the small capillary shunting only. But in type 2, we have small localized shunting point, which have a feeding artery, a rear feeding artery. And in a type 3 is DVA with EVM. And now the DVA come with EVM and is feeding by the IVM, by a rear IVM. Okay, let's go through the type 1 or diffuse shunting. A 49-year-old man suspected of having an arteriovenous malformation. On the DSA on arterial phase, you can see it shows the early filling of DVA in the middle cerebral artery, and in the late of arterial phase, you see the diffuse shunt, of that kind of capillary blush into the vein of lady, just capillary brush only, no feeding artery, no rear feeding artery. In type 2, now we have a rear feeding artery for the DVA. A patient, in here we have a patient who are suspected of having an AVM. See here on T1, we see a hematoma at the back of the brain with some kind of flow void beside, right? This kind of thing has increased signal on T1, so it is aqua hemoglobin or aqua methemoglobin, or which is more like present in subacute phase of the hemorrhage, and with some image of flow void when firstly, normally when we see that kind of appearance, we most likely think, this is a case of hemorrhagic IVM, right? With blood and flow void, definitely a hemorrhagic IVM, but it's not true. Let's see. Let's go through the DSA. Okay, on DSA we see the appearance. This is on arterial phase and this is on venous phase. You see the appearance of caput medusa appearance. Oh, this look like the palm tree or reversed umbrella with big collecting vein and a lot of radial vessels converging into a point, and it most likely present in the early arterial phase with an arterial feeding artery. The right anterior oblique projection in mid artery and venous phase confirm the presence of arterial DVA type 2. It's not a case of hemorrhagic. It's not a case of hemorrhagic IVM. It's the case of hemorrhagic arterial DVA. So be careful on your daily practice. Type 2, this is the image of 2.5 years later after a radial surgery, reveal an extensive of vasogenic edema surrounding an area with mixed signal intensity in the right parietal region, consistent with radial necrosis associated with hematoma. You see here on arterial phase of DSA, you see that the caput medusa appearance has been disappeared after the 2.5 year of radial surgery, but the collecting vein is still present. The collecting vein is still present, which explains why the patient still got the hematoma, the hemorrhagic symptom. And in type 3 of arterial DVA or DVA in AVM, DVA located in the drainer of AVM. You see here in the patient on T1, weighted MRI showed the left parietal hematoma with a lot of signal void, with a lot of flow void signal in here. And as normal appearance, as normal daily practice, we think about, oh, this is maybe the case of IVM, hemorrhagic IVM, right? With a local hemorrhage and flow void appearance, but it's not. It's not. Let's go through the DVA. This is the arterial phase of DVA, and this is venous phase of DVA. You see here on DVA with small nidus of DVA, which most likely supply small nidus of DVA of IVM, small nidus of IVM, which most likely supplied by thalamo and lenticulostriate artery, which is drained into a draining vein. But that kind of draining vein then become the collecting vein of the DVA. You can see it more clearly on the venous phase. So in case of the arterial DVA type 3 or IVM and DVA, the draining vein of the IVM become the collecting vein of the DVA. Here after the radial surgery, you can see the disappear of the IVM nidus. However, the collecting vein is still present, is still visible after the radial surgery. Okay, about treatment, an isolated developmental venous anomaly, normally it requires no treatment. It requires no treatment because they consider it as just an anatomic variation. It do not cause, it normally do not cause any kind of neurologic parenchymal problem or some kind of hemorrhagic. So normally just the anatomic variation. So it requires no treatment. And that kind of thing had very low complication rate, just 0.15% per annum. And most oftenly in case of isolated IVM, is the presence of thrombosis, venous thrombosis, a mixed vascular malformation, then treatment will be predicated on the other component, And DVA with early venous filling should not be a surgical target because the very high risk of including the catastrophic venous infection. Okay, and in case of DVA with IVM or arterial DVA type 3, sick case of DVA IVM or arterial DVA type 3 that underwent the treatment have been reported, and one was treated by proton beam radiosurgery, and one by surgery, two by embolization, and two cases by gamma knife. In 5 cases, AVM was successfully obliterated and DVIs were preserved. But in one case that presented with intracerebral hemorrhage, the AVM that were removed by the DVI, but the AVM were removed, but the DVI were disrupted unintentionally. As a result, the patient deteriorated due to massive venous infarction. Okay, in conclusion, the DVI is considered to be an extreme anatomical variation of medullary veins. The hemorrhagic cases that are most often attributed to DVA that associate with cavernous malformation. In rare circumstances, the DVA with arteriovenous shunts that are associated with hemorrhage and symptomatic of DVA are rare, and surgical treatment targeting the DVA should not be performed. Okay, that is the end of my presentation. Do you have any question for me?
Okay, thank you for your talk, Dr. Duy. I think that's this kind of interesting topic because normally in daily practice when I see a DVA, I don't have I don't pay any attention on it because that before your talk I think that is a kind of anatomical variance, and is no risk of hemorrhage or anything else. So I don't pay attention on it, but like you have mentioned in your talk, there is a high rate of association between the CM and the DVA, and as I mentioned in my lecture, this kind of association is very good for us to figure out the reason of the hemorrhage. In case that we see a hemorrhage and we see the DVA next to the hemorrhage, we can think of the cause of the hemorrhage is due to the CM, right? And in the article that you showed, the association rate is maybe more than 30%, and we cannot detect the DVA under 7 Tesla, right? And the other useful information is that the DVA can be come with the other kind of malformation, for example the AVM, and it can be the cause of the hemorrhage. And the last, I think the last phrase in this conclusion is very important, that the surgical treatment should not be performed in case of DVA only, because it can increase the venous infarction, right? The venous infarction. Yeah, and I think that this talk is give us more information about the things that we have is benign and it's just a variant anatomy, right? And I think that we should we should pay more attention on in case that we deal with a DVA on the daily practice. Okay, so anyone have any question or comment for this talk? Hello. Anyone is there? Everyone is there?
Okay, how we can differentiate between the TIP2 and AVM in the case?
Yeah, the question is the differentiating between the type 2 and the AVM.
So
AVM type 2 or arterial DVA.
Yeah, the type 2 of the arterialized DVA.
Type 2 has only the feeding artery. It has no nidus. It has no nidus in AVM.
Come back to the slide, please.
Okay.
Can you come?
Type 2 arterialized DVA, we just got only a feeding artery with no nidus, no rear AVM, just only a feeding artery. In type 3, we got a rear AVM with nidus. In here, we just have a feeding artery only, and come to the DVA. In type 3, we have a rear nidus of an AVM. That's the difference between type 2 and type 3.
Okay.
Doesn't make sense.
And I have a question. Is there any treatment move to the type 2?
Actually, to be honest, the arterialized DVI is a very extremely rare case, and just as I said earlier, just have a 53 case of arterialized DVI has been reported, and just 6 case treatment has been reported, and so there's a story between the treatment. I'm not really understand fully about that between type 2 and type 3.
And how about the article that you have mentioned about the venous of malformation, that benign or not benign? And can you talk a little bit about the case of malignancy in that article, please?
The benign, I think the term about benign or not benign, they do not talk about benign or malignant in the tumor, for like we really don't really understand. I think the benign term is, they are talking about that is that a thing that can cause the complication or not. I think so. So the thing that that do not cause the complication or benign is isolated DVA, and the thing that that cause a complication or like hemorrhagic, for example, like cavernous malformation with cavernous malformation or with the arterialized DVA.
Thank you. And one more that I don't understand. Can you tell me that between the combination of the CM and the DVAs, and between the type 3, the frequency of the hemorrhage is that equally, or it's got a really far difference?
Okay, you wanna know about the number, right? The number, the rate of hemorrhage. Okay, yes. You can see here on CM. Okay, in CM, you can see that the rate of hemorrhagic incident between cavernous malformation associated with DVA is the higher than 2.6 and 3.1 per patient per year. But in the type 3, in type 3 of DVA, we do not have here. I remember about this. It's quite high. It's quite high. Of course, the number is higher, but unfortunately, I do not give it in my presentation. But definitely, the risk of hemorrhage in the arterialized DVA is higher than cavernous malformation hemorrhage risk.
Thank you.
Okay.
No more question. Thank you.
Okay, thank you.
Thank you for your present, boss. I think that we should do this kind of stuff more regularly.
Sure.
Yeah. And you can notice as our resident is very good at foreign language in French and in English, so they can present the stuff in English and French very well.
Dr. Hung, I have question. In conventional MRI with the brain, is that we can negotiate? We can give through the DVA, or we have to describe it?
Sorry, your internet is unstable and I can't hear, your question clearly. Can you repeat it, please?
Yes, I have a question that I wonder if when we read the conventional MRI of the brain, if we see the DVA, it should be described or just detect it and go through.
I think that you should mention in your report that you see a DVA and there if and whether it is complication for in the case of white matter brain atrophy or whether it's come with the CM.
But just in description, or we have to mention for the result of the report.
I think it's up to you, right? Because maybe you can make the clinician upset or the patient upset, and I think that you should give your idea in your description. Maybe if there is no complication or there is no abnormalities, I think.
You, sir.
And the last thing, I think we need more the doctor to join the staff. It's better for the student and for the doctor.
Yes, I totally agree with you, boss.
Because some expert can give more the opinion. It's good for the student.
Yeah, I think so. Thank you, boss.
Okay, let's finish.
Bye bye.
Bye. Thank you for listening to me.
Mà đi đã tốt thôi.